This session 1 is William C. Campbell session. He won the Nobel Prize in the Physiology or Medicine in 2015 for their discoveries concerning a novel therapy against infections caused by roundworm parasites. For this session, we have the chairperson with us, Dr. Kamlesh Upadhyay from Ahmedabad and Dr. Jitendra Nagar sir from Disha. I welcome you, sir, and request you to introduce our speaker. First speaker. I request Dr. Kamlesh, sir, to introduce the first speaker. Okay. So we have the first speaker with us, Dr. Viral N. Shah, who is the Associate Professor at Barbara Davis Center for Diabetes, University of Colorado. His area of interest are in type 1 diabetes technologies, phase 3 clinical trials. He has won the awards of Communication Director, ADA Diabetes Tech Interest Group, ACE, ASAP Writing Committee member, and many more. We are so happy to have you, sir. Over to you, sir.
Thank you, Dr. Patel, for inviting me to speak at the SwasthyaCON. Last year, I came in person. I'm missing traveling this time with the COVID-19 pandemic, and I hope in 2021 or 2022, sorry, I would be able to attend that in person again. Anyway, I'm going to speak today on the artificial pancreas. It's also known as closed loop system. And where are we in closing the loop at this moment? So briefly, I'm going to touch on what is artificial pancreas system. As I mentioned that this is also called as closed loop system. So if I use the word AP or HCl, that means it is about the artificial pancreas. What are the currently marketed AP systems, particularly in the US market, because I'm more familiar with the US market than other markets, and what is their effectiveness in managing patients with type 1 diabetes. And just a brief about the future of AP system, what does that look like? And then I will have some concluding remarks at the end. So what is AP system? So artificial pancreas system is actually, it's a very simple concept. If the patient is using insulin pump, which delivers an insulin, and then patient use the continuous glucose monitor that monitors the subcutaneous or interstitial glucose every 5 minutes. In some CGM system, it's every 1 minute. We can easily connect two of them by means of mathematical algorithm, which in closed loop system is called as control algorithm. So meaning by that, by control algorithm, every minute or every 5 minutes continuous glucose monitoring glucose can be utilized to deliver insulin through the insulin pump. That's the concept of artificial pancreas system. Now, what are the components of artificial pancreas system? So as I mentioned, of course, the first component of that is the insulin pump. These are the pumps available in the US market. The last one, it's a Roche, which is not in the US market, but I included that here because I believe that it's available in India and certain part of the Europe. And then CGMs. So we have 4 CGMs in the US market, the Medtronic Guardian Connect, Dexcom. It has 4 different versions in the market right now, G4, G5, G6, and then G7 is coming by next year. Libre, which is widely used in India. So Libre also has now Libre 2, which is much better, improved version compared to Libre 1. And then Eversense, which is a first implantable sensor, which lasts up to 90 days in the US and 180 days in the Europe. And of course, the third part of this is called as an algorithms. These are the mathematical equations which drives the insulin delivery based on the CGM glucose values. And there are mainly 3 different types of algorithm. Again, I'm not going to go into the details of that, but I just wanted to touch on some important aspect of that. One is the PID. We call it a proportional integral, and derivative controller. This is kind of a more of a reactive controller, meaning by that, in simple way, it thinks about that where you are and where you should be. So for example, if your glucose target is 120 and if you're at 200, it will think about that, okay, you are 80 points above the threshold level. I'm going to give you X amount of the insulin to bring down to the normal level. And I call this as kind of a first generation or more of a reactive algorithm because it doesn't think about the prediction that what's going to happen in future. Should I do an insulin delivery based on the proactive steps or not? And this algorithm is being utilized in a Medtronic 670G system, which is available in the US at this moment. The second is the Modal predictive control. The name itself says that it's a predictive, right? So it tries to predict the glucose, that what's going to happen, and then it will try to correct based on the predictive glucose value. And a lot of system or future system is employing this MPC algorithm for artificial pancreas. And the examples are listed here. For example, Tandem, the Omnipod, the Beta Bionics, the Loops, and so many other systems. And the fuzzy logic, which is very interesting concept developed by Moshe Phillips from Israel, is that it actually is kind of an MPC, but it also takes into the account of the physician's perspective. For example, if the glucose is high, but then the patient is exercising, then you don't need insulin because the exercise is going to bring down the glucose. There are a lot of different kind of rules that the patient or physician can think about managing their diabetes or put this in algorithm so that the algorithm behaves like an MPC plus more of like how the patient or the physician is going to change the management based on various different real life factors. And this algorithm MD logic has been employed in a Medtronic 780G system, which is not approved in the US, but it's approved in the Europe at this moment. Now, what are the successful steps, or probably I would say, the future roadmap to have a fully automated system where you do not require any kind of a patient interference or patient navigation to operate that kind of system? So the first way or a first step, I call it a baby step of having a fully automated closed loop system is to shut off the insulin delivery when your glucose is low. This type of a system is called as a low glucose suspense system, LGS system in the Europe, or a threshold suspense system in the US, or TS system. The example is the Medtronic 530G. Now, again, a very simple concept shown here in this cartoon is that, let's say, for example, this red line is your glucose level. If the glucose level is reaching to an absolute threshold, and in this case, it's a 70 milligram per deciliter, then your insulin pump is going to stop the insulin delivery till up to 2 hours, or if the glucose is increased beyond certain point. So the idea is in preventing hypoglycemia or minimizing hypoglycemia rather than preventing hypoglycemia with this system. Now, remember that the system is not proactive. It's not a predictive. So it's not going to prevent every single hypoglycemia that you can think of. Now, what is the next step is that it's a predictive low glucose suspend. Now, the name itself says that the predictive low glucose suspend system, meaning by that, the system is going to suspend the insulin delivery based on the predictive low glucose. Now, again, shown in this cartoon is that here in this red line, the system is going to stop the insulin delivery. I'm just making this up at the glucose level of 150 milligram per deciliter because the system is thinking that your glucose is going to be less than 70 or 70 in next 20 minutes or 30 minutes. So system is trying to predict the low glucose and try to stop the insulin way earlier than you can have a low glucose. The advantage of this system is that this system is better than the threshold suspense system in preventing hypoglycemia. And the example is the Tandem basal IQ system, which is available in the US. Now, what is the third step or the next step is some kind of an hyper minimizer, meaning by that the system will give you more insulin or will stop the insulin based on your glucose on a higher side or a lower side. It will try to automate your so-called auto-basal rate, or maybe and kind of a small boluses, micro boluses, so that you are remained within certain threshold of glucose levels. We call this as some kind of a hybrid closed loop system. And why it's a hybrid? Because patient still needs to put their various datas into the system to have this system function optimally. And for example, the meal insulin. So the patient still needs to remember, needs to count the carbohydrates, put that into the insulin pump, and take the insulin to how the system works most efficiently. And the examples are the Medtronic 670G or 780G. The concept is again illustrated in this cartoon, is that the insulin pump will suspend the insulin when you are going to be low. Again, it's a predictive low glucose, and it's going to ramp up your microboluses or the basal rate if your glucose is going up. So it's trying to predict hyper or hypoglycemia and will increase or decrease the insulin delivery depending on the predicted glucose level. Again, it's not a fully automated system because patient still needs to enter the meal insulin. And the next step is going to be, of course, the fully automated closed loop system, meaning by that it will try to maintain your glucose in a normal range without much patient's interference to the system. Patient would not require any kind of like a counting of carbohydrates, putting that in meal boluses. There are various ways to do that. There are now some artificial intelligence has been developed that you can just take a picture of the photograph. It will calculate the meal composition that will be fed into this kind of a closed loop system, and the insulin pump will give you an automated bolus for your meal. Or it will also take the inputs from a different wearable device that you have. For example, if you are wearing a Fitbit, it will take the data from a Fitbit, and then it will know that when you are exercising or when you are not exercising, when you are sleeping or when you're not sleeping, so that it can modulate the insulin delivery depending on those factors to keep your glucose in as normal as possible. Now, two systems are available in the United States at this moment, which are hybrid closed loop system. One is the Medtronic 670G, and now there is a new version of that 670G, which is some minor modification, not in algorithm, but it's mainly that the pump is a Bluetooth pump, so that the future is that you don't have to buy a new hardware. You can just upgrade the software to upgrade to a different system. But anyway, so Medtronic 670G or 770G is available in the US. And I highlighted a research article that was published in JAMA that led to an FDA approval. The data clearly showed that the patient with type 1 diabetes using this Medtronic 670G had a significant reduction in the A1C and hypoglycemia after 3 months of use of this system. So clear-cut safety and the efficacy of system in improving glycemic control. Therefore, FDA approved that about 3 years back. The second system which got approval last year is the Tandem Control IQ system. Now remember that Tandem Control IQ uses the MPC, which is more of like a predictive algorithm or kind of a second version algorithm. And this randomized control trial, which was published in the New England Journal of Medicine, again clearly showed that the patients who use the Tandem Control IQ system had a significant improvement in A1C by 0.4% or higher, and significant reduction in the hypoglycemia compared to people who are just on a pump and the CGM, which is called a sensor augmented, but without any kind of an automated closed loop delivery. Again, that safety and efficacy of this study led to the FDA approval of Control IQ in 2019 in the United States. And this system has gaining more attention recently and preferred by many patients with type 1 diabetes in the United States. Now, this is what I talked about, the available system in the US, but there are other systems also available in Europe. For example, this is an example of a Diabeloop where this company uses some kind of like a very small patch pump with this very small infusion set, and it ties together with the Dexcom G6 CGM, and all data is displayed on your smartphone. So you don't have to have a separate receiver. It's just a smartphone which helps to control that, the algorithm part or a controller part, and automates the insulin delivery. But this is a French and it's approved in the EU market, but not in the US or the rest of the world. The another one is the Cambridge AP, smartphone app. Now this algorithm has been approved. Genius guy Roman Hovarka from Cambridge devised this and put that in a smart app, which is now approved in the UK, but not in the US or other part of the world. But if the patients are using, let's say, the Medtronic pump and the Medtronic CGM, and if they are using this app, now they can modify that pump and CGM by this controller so that they can use the artificial pancreas. Um, it's a long way to go for the US market because it still requires a lot of cooperation with the companies who manufactures the hardwares, like, for example, the insulin pump and the CGM. But the future, I think, would be very interesting because in future, and I'm going to talk about that interoperable system would make the patient uh, in a central role where the patient would decide about which pump or which CGM, which kind of a different algorithm to go for to improve their diabetes care. So this slide shows some kind of a future exciting products. One is the Omnipod Horizon closed loop system, which will be probably available in the US by early next year, hoping for so. But this is the only patch pump approved in the US. So it will be very exciting that those many patients who don't like the infusion sets or tubes of insulin pump, this kind of a closed loop system will be favorable to those patients. The Dexcom CGM, which is kind of a more popular in the United States, um, in patients with type 1 diabetes, they are also going to have a very small and newer version called as G7. And I think most of the artificial pancreas system will go for a G7 once it's getting approved um, because of various reasons. This is an example here shown as a Beta Bionics, which is a dual hormonal, meaning by that it will give you two different hormones, the glucagon and insulin, to regulate your glucose level. This is kind of a more physiological, right? Because your pancreas secretes not only insulin, it also secretes the glucagon. So whenever your blood sugar starts dropping, you have a more secretion of a glucagon in a normal physiology. So this kind of a artificial pancreas will try to have a more like a normal physiological mimicking artificial pancreas system. Another example is the Tandem T-Slim, which is more of like a modification in a pump rather than the artificial pancreas technology. Or Bigfoot. The Bigfoot is planning to launch their product probably next year or maybe so. And they are planning to have so-called some kind of an artificial pancreas system for even insulin injectors so that you can have a smart pen. You can use the mobile app based artificial pancreas algorithm. But again, it's not going to be fully automated system because patient still has to take that insulin by themselves if they are on an insulin pen. Now, but the idea is that they're going to create that kind of a loop for patients who are on a multiple daily injection as well as for the patients who are on an insulin pump. What does the roadmap overall look like for the artificial pancreas? And this isn't just an example of only one technology, and that's a Medtronic future products. I'm sorry. But this is true for most companies that are into this closed loop market. This will be looking like that the sensors and the pumps will have a very improved outlook. They will be longer lasting sensors. There will be no calibration. It will be very easy in the future. It will be some kind of a combined sensor and the infusion set so that the patient don't have to have two different devices attached to their body. The sensor will sense the glucose values and as well as the infusion set within that sensor will deliver the insulin as needed based on the glucose value. And of course, in the future, it will be all in one kind of a patch. So you have a small wearable patch which will deliver insulin, which will have an algorithm inside it, which will also have sensor or a glucose reading technology within that. And I think you can look all the data into your smartphone and you don't have to wear like a multiple devices. That's gonna be like kind of a future of closed loop system. And again, I showed you just the one example of a future of the Medtronic product, but this is gonna be pretty much similar for most of the companies working in the artificial pancreas technologies. So when we talk about the artificial pancreas, as I mentioned, that the one of the component of the artificial pancreas is the insulin pump, right? But in real life, in the world, the insulin pump are used only by a few patients. Let's say, for example, India, I think the less than 1% of patients with type 1 diabetes are using insulin pump because of the cost. So can we develop some kind of a closed loop system or artificial pancreas system for people who are using insulin pen or injections? It is possible. Again, it's not going to be fully automated system, but something that your mobile app, a smartphone based app, can guide you about taking your insulin more proactively based on various factors, based on the CGM glucose value, so that you can minimize hyperglycemia, you can minimize hypoglycemia, and you can be in a normal range as much as possible. And this is the one example here of an in control system where they are using a smart pen, smartphone based app, and the Dexcom G6 sensor. And this is in a clinical trial. I'm hoping it's done, and probably we will have the results pretty soon about this clinical trial, which will give us more idea about the efficacy and the safety of this kind of like closed loop system, but using the multiple daily injections or insulin pen rather than insulin pump. Now, the other concept devised by the FDA, and they gave an industry a guidance on that, it's called as interoperable devices. What that means, right now, let's say, for example, if you want to go for a Medtronic 670G closed loop system, you have to buy a Medtronic pump, the Medtronic CGM, and their algorithm. You do not have an option to select the pump from a one company, CGM from a different company, and the algorithm from a third different company. That restricts the patient's choice on selection of the different devices to optimize their glucose control. So what the FDA did is that they put some kind of a guidance for the industry that, hey, if your pump or if your CGM or if your algorithm meets this criteria or standards, which are very rigorous standard, then we will give you a designation of an interoperable pump or interoperable CGM. We call it iCGM or ACE pump in the United States. Once it's approved, then they have a slightly different regulatory pathway, which will make the future developments very easy for the company and faster, so that the patient can be a center of selecting different devices and can make their own choice about selecting pumps, selecting CGM, selecting different algorithms, and making their own kind of like, hybrid closed loop system that can work best for that patient. So that's kind of a future. There are a lot of ifs and buts around this future idea, but at least there is some kind of a guidance now by the FDA that will help the industry to move in that direction. Now, of course, even though this kind of a smart technologies will be available in the future, there will be some limitations, of course. There is nothing without limitations, right? The limitations of the current technology is, of course, that limitations associated with the insulin pump, for example, the infusion set, because if your infusion set get occluded, you are at the high risk of developing DKA because there is only one insulin, short-acting insulin in the pump. There are no long-acting insulin, which makes you at the high risk of severe hyperglycemia when your pump infusion set gets occluded, and if your pump gets malfunction or stopped working. So the limitations related to the pump, limitations related to the CGM, the inaccuracies of CGM, the limitations of CGM, the limitations of algorithms and devices are going to be the limitations of even hybrid closed loop system, because these are the component of the hybrid closed loop system. So these limitations are existing and probably will exist till we have a very smart systems which will probably detect all the problems automatically and try to correct those problems. without much of the patient's interaction. The last but the very most important limitation, at least in developing countries, in a context of India, is the cost. As I said earlier, that insulin pump, which is available for now almost 40 years in the developed countries, is still a barrier for majority of the patients with type 1 diabetes in India because of the cost. The cost of insulin pump, I heard that it's about 1 lakh rupees in Indian cost, which is probably a salary of many months for many patients with type 1 diabetes. So the cost is a major barrier. Now you have to think about that, the cost of the insulin pump, you have to think about the cost of the CGM, the cost of the controller, the recurring cost, because now remember that, it's not like once you buy the insulin pump, your cost ends there. You have to continuously change your infusion sets every third day. You have to change your CGM every 7 or 10 days, depending on what kind of CGMs you are using, or even 14 days for some CGMs. So there is a recurring cost. You have to think about those recurring costs and issues. And when you add up all the recurring costs, these kind of technologies, even though they are really good in managing diabetes, really helping patients to manage their diabetes, becomes cost prohibitive, at least in an Indian situation. And that's true even like in a developed world, like for example, the Europe or in the US, not everybody with type 1 diabetes can afford this kind of a system. So affordability is going to be a major limitation, despite we have a very bright future in the artificial pancreas technology. With that, I'm going to conclude my talk. So as I mentioned, the currently available hybrid closed loop systems are very safe in preventing hypoglycemia, very effective in improving glycemic control, which is A1C, in patients with type 1 diabetes. Now, remember, I'm talking about patients with type 1 diabetes. We do not have much evidences of using this kind of a system in patients with type 2 diabetes. Future system would be very simple. It would require less patient inputs, and it will be more automated. It might be using more than one hormone like insulin, glucagon, or amylin kind of a hormones, or GLP-1, rather than one hormone only, to improve the system's function. And the future is very exciting, but the cost is going to be a major barrier in adopting these technologies for many of our patients with type 1 diabetes, who would benefit from this system, but unfortunately cannot get into this system. With that, I would like to thank everyone, those who are attending this live webinar and attending this wonderful conference being organized by Dr. Patel. Thank you very much for having me. Thank you for your patience listening, and I'll be happy to have some questions after this. Thank you.
Thank you so much, sir. Uh, we have with us Dr. Kamlesh Upadhyay, sir, from
Yeah.
Ahmedabad, and Dr. Jitendra Nagar, sir, from Disha. So,
Yes.
Sir, if you have to say something about how was the session, and we have other case discussion lined up, but the speaker is among with us. So, if you want to say something.
Thank you, Mayur Bhai and Dr. Viral, Dr. Nagar.
Yes, sir.
It's a burning issue in the country, but as you rightly mentioned, cost is an issue. But in our government programs, school health programs, now we are picking up the more and more cases early, and we are looking forward for some games which can help this type 1 diabetes. Thank you once again.
Thank you, sir.
Thank you, Kamlesh Bhai. And then again, I would just say that thank you very much for serving the entire community of Gujarat. You are kind of like heard everywhere, taking lead in managing patients with the corona. So thank you. I really appreciate that.
Happy to see you. And after 1 year, we are.
I remember that still, like last January, I was there, and now I'm here sitting in my, either office or room here and doing a Zoom meeting all the time. So hope things will get better.
Yeah, it will.
I and Dr. Akhtar both got our second dose of Pfizer vaccine. I got today and he got yesterday. So if things gets better, I think we'll be good.
Thank you.